Welcome to CareTalk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, CEO of CareCentrics. David, how are you feeling today?
Oh, you say, how's 22 doing for you? Well, I took a vacation, but I ran into Omicron at my destination, John. So I guess it's the one to get, if you're getting it. So I have like a head cold. I'm like, what the heck,
Well, I hope you get better soon. It's this is a nasty virus. The only thing I'd suggest is don't underestimate it. In addition to being massively infectious, it's just not one to be underestimated. David, where are we in the Omicron tsunami right now? It is we got some fast breaking new waves of the virus. But what's your take on it?
Well, John, my take is that you see these numbers about hundreds of thousands or a million people a day getting it, and it's an underestimate. I did a home test, and my test I don't think is picked up anywhere. So I think it's the numbers are really much bigger, and what that means is everybody's getting it, and the wave should pass fast like it did in South Africa. And it's sounding like people are saying as soon as next week. Usually we want our podcast to have like a couple week shelf life, but Omicron may be in the rearview mirror in a week or two.
Well, I think it'll still be relevant, David. So I think the couple of thoughts on that one. One, there's no question that even though we are test short as a country, a lot of people are doing at-home tests, and it's not showing up in the statistics. So the actual infectivity and positivity rate is considerably higher than people thought. And the hospitalization rate related to COVID, particularly in ICU beds, purely as a function of the infections, is actually relatively low relative to Alpha and Delta. But the absolute mass of sick people or people who are sick with Omicron who need attention in the hospitals is crowding out a lot of things that are going on in hospitals. And I think that's going to first burn through, and you're seeing it in the numbers in the Mid-Atlantic region where hospitals are overwhelmed. It's happening right now in sort of the New York, Boston area. I think Philadelphia is quickly following thereafter. But I think that the waves will roll through the country, and hopefully, as a country, those waves will have burned through in January and February, and we will have, through some combination of having gotten it or having gotten our vaccination and booster rates up, really have pretty good resilience against this virus. But it still feels to me, David, like the testing failure on the part of the federal government is really one of the biggest challenges for people managing this. So we have to find a way to kind of live with this disease, whether we choose to live with it or not. It's going to live with us, as you're unfortunately dealing with.
Yeah. So I know you say kerfuffle, John. I know you didn't want to use the FU word because this is a family show after all, or it used to be. Maybe 22 it isn't. There is a challenge here. The first thing with the hospitalizations, there weren't enough ventilators. Now there's not enough doctors and nurses. And it's not just because they have COVID. A lot of them do. Is people are burned out. It's sort of, part of the problem is people have talked about, their individual right to do this, that, or the other. Well, what about the healthcare providers that we have to deal with? There's also a big impact you can see on the school-age kids. If they've been out of school, the school can't be staffed. You see it with mental health. You see it with educational delays. And I think we may be ready for the next part of the debate on trade-offs. What do we value as a country, and what are the behaviors that we expect?
Well, we're seeing it right now. And just this morning, the union in Chicago voted against going to school, even though the city and the parents expected the schools to be open. And New York, on the other side, is saying the schools will be open, because one of the things we've learned over the last year is if you close schools, the global damage you do to development and depression and mental health and not socializing is actually quite substantially and consistently more dangerous for children than getting the virus. And yet some school districts are going back where they started. Now, there's genuinely a staffing challenge. You've got a lot of people who are testing positive and appropriately isolating. But we're going to have to find a way to work with this virus. And I think that the failure to plan and execute on the part of the White House with regard to providing low-cost testing the failure to understand the reality of the need to approve tests, which the FDA has consistently screwed up. We could, David, there's hundreds of tests we could actually buy from the rest of the country if we would approve them. And instead, we were kind of hung up with massive, long regulatory delays on testing. And we solved that problem around vaccines, and pretty quickly we're solving it in therapeutics. But we've got to solve that testing problem, and then people could actually kind of could stay home and isolate and lower the absolute weight or number of people who are sick, and put less burden on the hospitals. Because I do think that, I mean, look, 60% of all healthcare workers are complaining about burnout. The Bureau of Labor Statistics says that we will lose about 500,000 nurses by the end of 22 who just have chosen to retire. Suicide rates are up with doctors. We're putting an unsustainable burden on the healthcare system, and it's one of the things that people aren't talking about. But it is a little bit of a function of the fact that even though we've got the vaccines right, we still need to fast track therapeutics. We need to broaden the aperture of what we'll approve in terms of diagnostic tests. And we've got to lower the absolute burden on the healthcare system, because it doesn't just affect those people who get sick with COVID, whether it's upper respiratory tract or cardiac or whatever, or just being depleted and vulnerable. It's crowding out things like cancer and cardiac care. And we've got to, I don't think we're going to win completely on vaccinations. So we have to make more progress on therapeutics, the things that you take if you get sick, and broad access to low-cost testing. I mean, the notion that, I don't know what you thought of the Biden administration saying, well, insurance companies should cover tests, and we'll come up with regulations sometime in January. I mean, it's crazy. And now we're in a situation where many people can't get tests, and where they can, the prices are going up.
John, there's a lot in there. One of the little things that happened at New Year's is, the No Surprises Act went into effect. So I know you like a good surprise, John, but a surprise medical bill is...
So you're not going to even follow up on all that Omicron and national policy. Fine. Yeah, no, the No Surprises Act is actually a really important... It's one of the few things that both parties agree on. I don't think there's a political leader that's in favor of surprise medical billing. And what's striking is how frequently people who are not covered or undercovered get these massive surprise bills. Everybody gets some, but it is a particularly dangerous practice that doctors, ancillary providers, and hospitals do to bill kind of whatever they want to charge for the non-negotiated prices that a hospital or doctor gets to charge, often for a family or a patient that's in the middle of a crisis. And finally, for the population, Congress passed a bill that said, you got to charge your in-network negotiated price for the vast majority of like emergency services, air ambulances, at the same kind of with the same kind of co-pays and co-insurance, so that at least it's possible that you'll be charged a fair price. But so I think this is progress. It sounded like you were about to say something snarky about it.
No, John, I'm a well-insured guy. I could go to my mailbox and I might have like a dozen pieces of mail. I get a couple pieces of junk mail and I go, surprise, surprise, surprise. I could have one surprise bill after the other. Surprise medical bill is when the reason you're surprised.
Hey, David, have you ever, I'll lead the witness here. Have you ever gotten a surprise medical bill
Every day.
In the last 6 months?
Every day, John. I seem to get a surprise bill all the time. And what happens is I have good insurance and I go to a hospital that is in network, but then I may be treated by somebody who's not in network at the hospital, like in the case of an emergency department. They go.
How would you know? I mean, you're sitting there, after your UFC fight and you've been knocked out, and you wake up and they're doing some work on you. Like, how do you even know?
Yeah. Well, you don't. The thing is, of course, we don't have to get into the reasons I've been to the emergency room, John, but they usually do have to do with something stupid that I might not be in a position to say. Are you going to surprise me with a bill after this? But what happens, John, is that, you could generally expect a lot of these do happen in the emergency department. Ambulance is another area, which is actually not covered, ground ambulance. But you'll get a bill that's really super high, and they'll go after you. They'll go after you hard.
Like how high could that ambulance bill be?
So I had an ambulance ride of 1.5 miles, and it was from my home in Brookline to Beth Israel Deaconess Medical Center, and it was $4,000.
And you couldn't walk because you were hit by a car.
Couldn't walk because I was hit by a car. That's right. And if I'd been in Boston 1 mile or 2 away, first of all, the car might have been going faster, and I would have been whacked, and I just would have needed, a hearse. But that would have been $500 because that's how Boston does it. But they charge what they want, and
the hearses are cheaper, or
well, you get the hearse eventually, but that's usually a one-way type ride. But John, with these surprise bills, what happens is they stick it to the patient to have to deal with it. And now the main part of this No Surprises Act is that they force the provider, that is the doctor, the hospital, to work it out with the insurance company. That's kind of the essence of it. And that's what should happen, because there's no way a patient could handle it. Now, you better watch out, because not just because Santa Claus.
Hear this now. This is a consumer advice.
Yeah. Okay. So
explain it,
so
David.
John, one of the things that you can do is the provider doesn't like it, maybe, that they can't send this bill, because they don't look at it as a surprise bill. They're like, I need to be paid for my services. And so they can ask a patient to waive their rights. And you can imagine how that's going to be framed. They're not going to say, waive your right to what's correct for you. They're going to say, the hospital, the insurance companies don't pay what I need, et cetera, et cetera. And so you just need to sign here so you can be treated. So watch out. You do not have to sign that waiver.
I think it's really a critical thing. I mean, again, this is a really bad practice that has become common. And, one of the fastest reasons, or the biggest reasons for people declaring bankruptcy is healthcare bills. And some of those healthcare bills are these surprise bills that people get, which are insanely priced, and that particularly poor or undercovered people can't afford to pay. And you've got to watch. You can't let yourself put yourself in a situation where you've waived those rights. So read all of those incredibly boring forms carefully when you're signing yourself in and going through your privacy and your coverage. When if you're in the unfortunate but probably common experience that you're experiencing some hospital, and you make sure you don't waive those rights away. So David, what about, speaking of high prices?
Yeah.
I thought we were making great progress with your buddy Trump's MFN drug pricing, where
Me too.
The premise was that the U.S. was not going to cover or pay for drugs at any price higher than another country would pay. So if a bill costs a penny in Egypt, it shouldn't cost more than a penny here.
Yeah.
That did not turn out to be the case. In fact, CMS blew it up.
Yeah.
In this, what's going on there?
John, this is an interesting one. The former president was scheduled to hold a press conference this week, and everybody assumed it was going to be about the events on January 6th at the Capitol. But I think he actually wanted to talk about drug pricing. And so the idea was that, hey, we can't figure out how to pay less for drugs. So let's just let New Zealand, it's not Egypt, but some of the more, the richer countries, do our dirty work, and whatever they pay.
Industrialized country.
Yeah,
it was just
whatever they pay.
We got to be a little bit more provocative, David. Egypt, in some cases, is literally, drugs in Egypt cost like 5 to 10 cents on the dollar relative to what the same pharma company charges the American government and the American citizens. But yes, so fine. I'll give you New Zealand.
All right, John.
As long as I get to keep New Zealand pricing and I don't have to pay New York prices.
Yeah.
What happened here?
Well, so John, what happened was that this should make you concerned, okay? Because CMS decided to get rid of it, probably because they want to get rid of all Trump era things. But get this, the drug companies are happy about it, and the providers are happy about it. And that probably means,
oh no,
not good for the consumers. If something that both the hospitals like and the drug companies like is probably not good for the consumer. Can you tease that one out for me, John? Why do the drug companies and the hospitals like the same thing?
Because they both make more money, David. Would that have something to do with it?
So the drug companies is kind of obvious, right? So if you say I have to pay a nickel rather than a dollar, the drug companies don't like that. But in a lot of cases, the hospitals or the doctor's office, they may make a percentage markup on that product. And so, yeah, they may say, well, I don't like it, but sure, I'd rather take 4% of $1,000 than, or, $100,000 than 4% of a nickel. So, yeah, so consumers should be suspicious, John. And I'm glad that you're alerting the public and doing your usual public service work there.
Well, I was just surprised that they backed, the Biden government backed off of it. Any sense as to why they did that?
I just think it was meant to be a demonstration project, and it's probably, they're going to pick their battles. It's going to be somewhere else. It's interesting if you look at what happened with Medicare. The Part B premium went up a lot this year. That's another thing that the senior citizens, anybody on Medicare will face. The two reasons for that. One is that 2021's increase was held down artificially because of the pandemic, didn't want to push it up there. But also the drug whose name I can't pronounce to your satisfaction, John, from Biogen, Aduhelm. Aduhelm is the drug that they thought that people would take so much for dementia and be so expensive that it would actually be a huge reason for the Part B premium going up.
This is the extremely expensive Biogen anti-Alzheimer's drug that, based on the clinical data that was presented, barely got approved because it's unclear that it has much of an impact on Alzheimer's at all. And the one impact it will have is it'll kick your pocketbook at the federal level because Medicare is the most likely payer here, and it's extremely expensive.
So, John, I think
so. David,
yeah.
So walk me through why we're not making progress on pharma pricing. This is kind of crazy.
I think we are making a little bit of progress. So one of the things that happens is pharma will say, okay, I need higher revenue, so I'll just raise the prices on drugs that are out there. And we've seen this happen, multiple times a year.
Every year.
Yeah, but more than once a year, John. And you'll see like a 9.9% increase. It's the same reason with the gas station. It's, $2.89.9. They don't want to say, how much it really is. But they just push it up. But what's happened actually, John, is there's a number of drugs where the price went up about 4.9%. Stat had an article about this. But they're actually just pushing them up now sort of once a year. And they're trying to avoid scrutiny for these big price increases. So that's one part of it. And frankly, John, there's inflation in Biden's America. And so there's a lot of things that are going up at 5% a year. So that doesn't bother me too much. The next focus is on the launch prices, right? Because it's, okay, I can't get a big increase, so I better charge a lot when I put it out there. That's what Biogen was doing. Now they've actually been forced to take that one down. So I think if you look at those two things, the increase of prices of drugs that are already on the market and the launch prices, there's a little bit of a glimmer of hope on both.
I think you are getting way too optimistic. I think we've lost again to the pharma lobbyists. I think we got to keep pounding on this one. We are not; these were modest changes that should have happened, and again, we're not really restraining at the point at which I choose not to overcharge you for the first part of the year, but I overcharge you even more for the second part. I think it's it's the economic equivalent of kind of a battered woman. I mean, I just think
John,
we're starting to
it just offends you.
Assume it should, because the federal government as voters. And we pay for a lot of the research, then we cover these drugs, and then we pay the highest prices in the world. It makes no sense. And 1 out of 4 people who are chronically ill on chronic meds can't afford their meds. I mean, it's insane. But David, what else is happening with Medicare this year? There are some other changes in 22 that we should cover, because Medicare is one of the biggest payers in the world.
22 is all about you. I'll mention one more drug-related one, which is that, you're always whining about the cost of insulin. You think, just so someone's a diabetic, they should be able to get their insulin. Okay, yeah, blah, blah, blah. So,
yes.
So they've now actually do have a specifically addressing the cost of insulin for people on Medicare. So that's actually been addressed in like a kind of a piecemeal fashion. But there's also, we talked about...
Oh, really? And how effective do you think that's going to be?
Well, I think it's one of those where the drug industry said, yeah, we don't look very good on that one, so we'll give up on that one, and we'll fight to protect the others. I'm not sure it's going to be that effective, but if you need insulin, it's probably helpful. There's one other, John, and maybe you have some others up your sleeve, because I know you're deep in the wonkery, but mental health, we've talked about, is a big issue, and not just for teenagers, although that is a big factor, but for people on Medicare as well. And there will be coverage this year, permanent coverage starting for mental health for telemedicine. So I think that is a good improvement. And
that's a major step in the right direction.
So that's the other thing I know. Did you know?
Again, I think the most dangerous thing for Medicare over time is we're still not dealing with the affordability issues. You've got 10,000 people becoming Medicare eligible every day. We've got, those are the folks who are over 65 or, aging into Medicare. We've got increasing prices, a stressed healthcare system where doctors and nurses are both threatening to quit. I think that something like 2/3 of all nurses have thought about quitting in the past year, just based on how hard they're working, and frankly, how unrewarding the work is, because they see a lot of unvaccinated people getting extremely ill, and we're losing a lot of people. We lost a generation of older people. Nearly 1 million people have died. I mean, it's a heavily tilted towards the elderly. But there are the pediatric wards are overwhelmed right now. I can't imagine how stressful that is.
Yeah.
So I think we've got to continue to innovate around ways that we can extend the labor we've got, and we got to respect. I return to where I started, the human toll, and frankly the human needs of just the battlefield fatigue of all of our great healthcare frontline providers. We were clapping for them at the beginning part of the pandemic. And playing music, and they are the healthcare heroes. I think it's even more important right now that we not just celebrate their courage and their tenacity in the face of these rolling waves of virus, but we come up with ways to make their jobs easier, because what we're now putting through at a human cost is unsustainable, and that's going to be even more dangerous as America gets grayer and older, with all of the attendant healthcare needs.
Well, John, before we let all the fizz out of the New Year's Eve champagne, I want to say I hope 2022 is going to be good for you. And I'm looking forward to podcasting all year long with you, cresting this wave and getting on to bigger and better things. So with that in mind, that's it for another episode of CareTalk. I'm David Williams, president of Health Business Group.
And I'm John Driscoll. And back at you, David. Let's have another great year. And I hope that this year will be even better from a healthcare perspective, but there'll still be plenty to talk about and argue about. If you like what you heard, and would like to hear more, please subscribe. And thanks for listening to CareTalk.